opportunity to be here this morning. And I'm going to talk about something that, overall is pretty rare in ophthalmology, but it's something that I see every day in my clinic. So I'm just going to review some of the more recent advances in prognostication that we have for uveal melanoma. Uveal melanoma is the most common primary intraocular malignancy in adults. Good. Thank you. So this is a rare malignancy. Many ophthalmologists will go through their entire career and maybe see one, maybe two cases of this. The age-adjusted incidence in the United States is about 5.1 individuals per million, and the 5-year relative survival in this disease is about 81.6%. This is a paper that I worked on just a couple years ago, sort of tracking the incidence of uveal melanoma, trends in incidence, survival, and treatment over the past several decades. And we did this by looking at data from the Surveillance, Epidemiology, and End Results database. This is a national cancer registry that was started in 1973. When I conducted the study, there were 14 different registries that we pulled data from. And there's approximately 170,000 cases that are ascertained each year. SEER estimates that they have about 98% case ascertainment, which is excellent. It's updated every year, and the data is available free of charge to the public. So this is an excellent source of cancer statistics. And what we have found, going back to 1973, is that the incidence in uveal melanoma has fortunately remained relatively stable. So overall, I gave you that number, that there are approximately 5.1 cases per million, so a very rare disease. What we also know is that there has been a change in trends in treatment. So while we used to perform enucleation or removal of the eye, we now more commonly are able to give eye-sparing treatment such as radiation with plaque brachytherapy or protons in some centers. And the reason for this is that we now know from the collaborative ocular melanoma study and others that plaque brachytherapy is equal to enucleation in terms of overall survival. So whenever possible, we perform an eye-sparing treatment. And fortunately, survival has remained relatively stable at 81.6% at 5 years. So just think about that. In all that we have learned about this disease, and we have become better at diagnosing it, better at treating it and preserving the eye, but survival hasn't changed over the last several decades. But forget about what I just told you over the last 3 decades. Look way back to the 1800s. So you may recognize this is Ernst Fuchs. He's one of all the most famous people in ophthalmology. This is one of his papers on sarcoma of the uveal tract, which is uveal melanoma, what it was called back then. And what he's telling us in his patient population is that 18% of his patients develop metastases regardless of how he treats them. So he says 18% develop metastases, and I told you 80% survive at 5 years. So we're telling you the same thing. His glass is half empty and mine is half full, but it's the same. Nothing has changed in survival in this disease over all these years. So why is that? That's because this is a very aggressive cancer. We think that at the time of diagnosis in the eye, the cat is already out of the bag, so to speak. It's a systemic disease, such that micrometastases exist in the circulation already at the time when we diagnose the eye tumor. There's often a prolonged latency between when we diagnose the tumor in the eye and when patients develop macrometastatic disease. 90% of the time, this shows up in the liver, and in the remainder of cases, it's in the lung. Once we diagnose tumors in the liver, median survival is only about 6 to 9 months, and this is regardless of the kind of therapies that we can offer, whether it's surgery for select cases, standard chemotherapy, or selective chemotherapy delivered through the hepatic artery, etc. So this strategy is to predict which patients are at the highest risk to develop metastases, to find those metastases early, and to treat them, preferably with adjuvant therapies so that this doesn't happen to begin with. So that brings us to prognostication and where we are at now. Some of the earliest prognostic indicators that we had were clinical features, and these were identified in the 1970s We know that larger tumors are more likely to spread. When we look back at the data from the collaborative ocular melanoma study, and when we followed those tumors out for 25 years, we found that 18% of small, 52% of medium tumors, and almost 60% of large tumors had metastasized. So size matters. Tumor location is important. Those that are located anterior to the equator or those that involve the ciliary body are often diagnosed later when the tumors are large. And of course, extrascleral extension is also a risk factor for metastasis. We also know that growth patterns are important. So this picture shows you what I would call sort of a diffuse form of melanoma. It's flat like a pancake. So even though the thickness itself is only about 1 millimeter thick, you can see that the base is about 16 to 18 millimeters. This is a huge tumor. Ring melanomas and those that grow rapidly are also more aggressive. We also know that patient factors are important. Patients with advanced age or male gender, for some reason, tend to do poorer than younger patients. Histologic features are also important. Cell type, epithelioid tumors are more aggressive than spindle A and spindle B tumors. High number of mitotic figures, presence of tumor-infiltrating lymphocytes, and extravascular matrix patterns are indicative of prognostic factors. So cytogenetics really became important in the 1980s. And the earliest studies used standard karyotyping. And various aberrations in chromosomes, particularly chromosomes 1, 3, 6, and 8, seem to be key in finding high-risk features for metastasis. And of all of those, the tumor that is missing one copy of chromosome 3, or so-called monosomy 3, seems to be the most important in identifying which tumors are likely to spread outside the eye. So the biggest challenge that we have now is that this is a very rare disease. So when you look at all major centers across the United States and across the world that see these eye tumors, everyone has a different kind of local expertise. So you can find monosomy 3 using many different assays. Some use FISH, some use spectral karyotyping, CGH, microsatellite analysis, SNP arrays, MLPA, and now we have gene expression profiling too. So there are many different ways to sort of get at finding these high-risk features, and people use what they are locally comfortable with at their institution. So there are many different techniques, and then the other challenge is that there's great variability in these techniques. So you can use either fresh tumor tissue, or if you've been doing this for 20 years and you have a huge bank of paraffin-embedded tissue, you may use that. You may perform fine needle aspiration biopsy, and that can be done in a number of different ways, which I'll show you in a minute, or you may have access to enucleation tissue. The issue is that there are many different assays and there are many different techniques, and so it's very hard to do head-to-head comparisons about which is the best assay or which is the best technique to use. This is how I perform the biopsy. I use a 25-gauge needle with short tubing on a 5 cc syringe, and then the sample is collected in a fixative such as Cytolite. There are various different needles you can use, and in the picture on the right, I'm showing you just a standard 25-gauge needle, and then in the picture on the left, you can see the needle has markers on it. Those are 1 millimeter markers, so you can see that the depth that you're penetrating into the tumor, and that is somewhat helpful. Depending on the location, a different technique may be used. So for iris melanomas, you can use a transcorneal approach. For anteriorly located tumors, you can make a little transscleral flap in the sclera, and the needle can go in through an outside approach. And then for posteriorly located tumors, usually the needle goes in through pars plana and 4 millimeters posterior to the limbus, and we pull out tissue this way. This is what the typical cytopathology looks like. This is a particular tumor that has spindle cells, and you can see the melanin in the cells. In the picture on the right, you can see the tumor before the needle biopsy is done, and in the left, you can see that there's some localized hemorrhage, and that usually clears over a course of several weeks. We know that we can do this safely. There have now been multiple studies with relatively large series. In our center, we had 130 consecutive cases where needle biopsy was performed, and non-clearing vitreous hemorrhage requiring further surgery occurred only in one case, and a rhegmatogenous retinal detachment occurred only in one case, so less than 1% complication rate. We have learned to avoid biopsying small tumors, specifically those that are less than 2.5 millimeters in height, because we know that there's a high probability of getting insufficient cells for prognostication, and that leads to an inconclusive biopsy, and I think it's not right to put the patient at risk when there's a high likelihood of not getting a prognostic biopsy. I'm going to talk a little bit about fluorescence in situ hybridization, or FISH, because I have some experience using this technique. FISH is it's a nice technology. It's a visual technology which uses fluorochromes which are linked to DNA probes. You can either use a probe which is specific for the centromere of the chromosome, you can use a whole chromosome paint, or you can use a locus-specific probe for an area of interest. This is how it looks visually. So in the picture on the right-hand side, you can see that you're getting 2 red signals for the centromere of chromosome 3. So this is what we call disomy 3. We know both copies are there. This patient has a good prognosis. And then on the left, you can see that there's only 1 red signal in each cell. So this patient has lost a copy of chromosome 3. This is a high-risk tumor, high probability of spreading outside the eye. And in fact, this is what you see when you do Kaplan-Meier survival curves, is that the patients who have monosomy 3 do more poorly than those who have disomy 3. More recently, we have gene expression profiling. This was primarily developed by Bill Harbour and his group. And gene expression profiling is able to do some risk stratification such that patients are grouped into one of 3 classes. Either their tumor is class 1A, which portends a very low risk of metastasis, class 1B, which is intermediate, and those patients tend to develop late metastases, and class 2, these patients are very high risk. This is what the report looks like after the assay has been done and it's returned to you. This particular patient has a class 1A tumor, so this is good news, and this is how the numbers stratify. So someone who has a class 1A tumor, 98% of those individuals are metastasis-free at 3 years, and 98% are metastasis-free at 5 years. You compare that on the bottom line to those who have class 2 tumors, only 50% are metastasis-free at 3 years, and only 28% are free of metastases at 5 years. So where are we going with prognostication at present? I think that in all of the different ways we have to get at these high-risk features, we have ways to innovate in the technique. So I told you that I have familiarity with FISH. You can use more than 1 probe. You don't have to use a centromeric probe. In fact, I did another study where we used a locus-specific probe for 3p25, which is very near the von Hippel-Lindau tumor suppressor gene, and we found that that was actually better than using centromeric probes. You can also use many different colors for FISH, so you can, instead of just using 1, you can use multiple ones if there are many areas of interest that you're looking for. Circulating tumor DNA is another hot topic, and it's been shown to be suggestive of metastases far in advance of where you can pick this up on a CAT scan or an MRI. That's been demonstrated in other cancers like lung cancer, breast cancer, GI cancers. But eye melanoma, this has really not been explored yet, and I think that that's something that we should exploit, particularly as these tumors demonstrate mutations in GNAQ and GNA11, BAP1, and others, and so we should be able to detect these in circulating plasma. Proteomics and epigenetics are also areas of interest. So the key is to find the patients that are high risk and then to be able to give them adjuvant therapies. When I started my fellowship several years ago, there were only 1 or 2 adjuvant treatment protocols in the United States. One of them was at the Cleveland Clinic where I was working at the time. And this is relatively recent, from just a couple of months ago. I looked at clinicaltrials.gov and put in uveal melanoma and prognostication, and I came up with 24 hits. So there's much more going on now than there was several years ago. So this area is really expanding and just zooming very quickly. So in conclusion, there are many available prognostication techniques. We need to develop better adjuvant therapies, and it's very important to collaborate between centers because this is a rare disease and all of us have a handful of patients. But if we combined our data and work together, we can make good progress in this area. Thank you very much.